Ladies and gentlemen, welcome to this Healing Hands webinar. I'm Adrien Naveau, and I would like to begin with thanking Uvoh and Onoriobe for this opportunity to make a webinar. When Uvoh sent me this invitation, I went on the Healing Hands website and realized there were very few maxillofacial prosthetic lectures. And a few days earlier, there was an ICP webinar during which somebody complained about the difficulty for African prosthodontists to find educational webinars about maxillofacial prosthetics. So I figured this could be a good opportunity to talk about some basics, such as maxillary obturators. Because after a maxillary defect, most of the oral functions are impaired. And if a surgical reconstruction is not possible, patient can benefit from an obturator prosthesis. So we are going to talk about maxillary obturators, about the current ones, and a little bit about those from a foreseeable future. As the webinar format might be too short to develop some concepts, I invite those seeking for maxillofacial prosthetics lectures to go on the Foundation for Oral Facial Rehabilitation website. You will find some free and comprehensive PowerPoint presentations from John Burmer III. He has led the UCLA Maxillofacial Prosthetics department for 45 years, and he has written the Maxillofacial Prosthetics reference textbook. So during my presentation, I marked some slides in this corner. And before we start, just a word about me, to say that I'm Associate Professor in Prosthodontics at the Bordeaux University Hospital in France, and I'm head of the dental department of Saint André Hospital. I also do research in a tissue engineering lab called Biotis. So if you want to know more about bioprinting, I recently recorded a webinar for the International College of Prosthodontics. So here we are, and I'm going to start with the traditional definition slide. And as a subspecialty of prosthodontics, maxillofacial prosthetics is concerned with the replacement of part of the stomatognatic system, meaning mouth and jaw, and craniofacial structures. The definition in the previous glossary of prosthodontic terms associated a notion of removable prosthesis, but it disappeared, probably due to the rise of implant fixed restorations. These prostheses, obturators, can be intraoral, extraoral, or both. The palatal obturator is, of course, an intraoral prosthesis. This prosthesis, that can be as simple as a palatal plate, is sometimes the most rewarding prosthesis, as it can easily restore some social life for the patient. Palatal defects are mostly acquired. They either result from tumor removal, such as squamous cell carcinoma, or from trauma, fungal infections, osteonecrosis, or cocaine. The typical acquired maxillary defect results in an oral communication with the nose and or the maxillary sinuses. This creates infections, physiological and functional deficiencies in mastications, deglutition, and speech. The social impact is very impairing, especially when the defect also affects the cosmetic appearance. Deglutition and speech are the major deficiencies directly addressed by obturator prosthetic management during the early cares. The objectives of the obturator prosthesis are to restore the partition between oral and nasal cavities for speech and swallowing, to restore the palatal contour and replacing the missing dentition for speech and chewing, and to prevent leakage from liquid into the nasal passages, thanks to diverse extensions. And lastly, to provide retention, stability, and support for the dental prosthesis. When compared to surgery, the prosthesis advantages are the possibility of surveillance of the surgical defect, the cost, the fabrication rapidity, and the possibility of evolution, and so on. They, however, present some limitations. They are artificial, removable, they are needed for drinking during the night, and they require heavy maintenance, and often the obturator does not allow to fully reach the objectives. The size of the defects and the abutments provide most of the limitations. Various obturators have been developed over the ages. Briefly, although it existed before Ambroise Paré, he was the first to precisely describe a golden device with a sponge and to call it an obturator. Another big step was the first surgical obturator described by Claude Martin in 1875. And as you can see, I have a very French vision of history. This palatal prosthesis evolved very slowly until the ones we're about to talk. And if we have a look on the publication topic in maxillofacial prosthetics, we can see that during the last decade, a new category emerged, the CAD-CAM category, with keywords such as rapid prototyping, tomography, and 3D printing. We'll see later that these technologies are changing rather the obturator fabrication steps than the concept itself. So there have been many classifications for describing maxillary defects. The most famous ones are Aramanis. The interesting thing about this one is that it was designed by the dentist like a removable partial denture classification with metal framework descriptions. The second one is bronze. This one comes from the surgical approach, and interestingly it characterizes the palatal defect and the vertical component. And the last classification I wanted to briefly mention is Kolb's. It's not very famous, mostly because it was, I think, published only in French. However, I like its design, as it describes the palatal defect as a function of the remaining canines, a bit like Aramanis, the vertical components, like bronze, and the soft palate defect. Moreover, it shows the surgical and prosthetic solution for each situation. So my interest in this classification is the fact that obviously there are still a lot of indication for obturators. Anyway, let's start with nowadays palate obturators. The first obturator is fitted the day of the tumor removal surgery, and it's called a surgical or an immediate obturator. The provisional obturator is made after the surgery, but before complete healing, with impressions between 3 weeks and 3 months after surgery. And the last one, the definitive obturator, comes around 6 months to 1 year after healing, and so relining are less frequent. So let's talk about surgical obturator first. The objectives of the surgical obturator are to provide a matrix for surgical packing, to reduce contamination during healing, to enable speech and deglutition, so there's no need for a nasogastric tube, to improve psychological acceptance of the patient, and to reduce hospitalization lengths. Money is involved. The fabrication requires a coordination between the surgeon and the dentist, which seems to be kind of difficult in most of the hospitals, unfortunately. At this early step, in theory, the medical team should agree on a procedure, and that's the opportunity for the dentist to ask for some specific surgical management of the defect to enhance the prosthetic prognosis, but we'll review some later. The surgical obturator itself does not need to be very sophisticated. It has to be simple, lightweight, cheap. It could be even an existing denture or record base. It can be perforated for wiring to residual dentition. Normal palatal contour should be reproduced, and it should terminate short of skin graft mucosal junction. And whatever device is chosen, no occlusion at all on the defect side. So we want to guide the healing to avoid flanges, to limit the tissue fibrosis, and to maintain the function as much as possible. This obturator will be realigned and modified until complete healing of the defect. The simplest obturators are those done without any dental consultation prior to surgery. Could be due to surgical emergency or to the absence of prosthodontist. So we'll find gauze retained with wires, could be a ball of VPS, high viscosity, or it could be the current prosthesis, either with silicone or retarded setting resin. Otherwise, if it has been possible for the prosthodontist to meet the patient before the surgery, the dentist can make an impression of the maxillary arch, remove on the plaster the teeth as planned by the surgeon, and make an immediate palatal plate. This plate will be used for supporting the defect filling material during the surgery. If the patient is completely edentulous, the plate can be fixed with wires to the remaining bone by the surgeon. But these plates can be more elaborated. I found on PubMed some funny techniques to make cheap immediate denture for supporting the surgical obturator. These work only if the patient has most of the teeth before surgery. During the first appointment before surgery, Patil and colleagues made an impression of the maxillar arch. They obtained a cast and made a palatal plate. This plate was then fitted in the mouth during the second appointment, and they took a wash impression of the plate in the mouth. On this new cast, they removed the plaster corresponding to the future defect, put back the impression on the plaster, and poured dental resin for the teeth and then pink resin for the gum borders. And this way they have a cheap denture for support, but requiring 2 appointments and a lab time. So here's an even faster technique to make an immediate denture. Farias and colleagues drew the defect margins on an alginate impression and poured it with white and pink resin again. Then they poured plaster on the composite alginate impression and finished the plate realization. So I think I'll try this one because the surgical obturator might be suitable to be turned into a provisional obturator. So now we'll see the provisional obturator, which role is to wait for the tissue remodeling to be complete. The impression of the defect is a big difference with the surgical obturator, and it occurs usually between 3 weeks and 3 months after surgery. This prosthesis will be relined multiple times to maintain the sealing of the defect. Indeed, it takes approximately 1 year for tissue stabilization due to scar contraction, graft smoothing, and edematic grease. Sometimes a surgical obturator or a former prosthesis can be relined and turned into provisional obturator, if it was functional enough. Sometimes also you can find in the literature another category of obturator. It's called the post-resection obturator. In this case, the impressions are made at the end of the removal surgery, while the patient is still asleep in the operative room. So the fabrication of the obturator is then similar to a provisional obturator. As for definitive prosthesis, the provisional obturator will be either part of the dental prosthesis or removable. The removable obturator allows a better retention by using multiple undercuts. Unfortunately, the silicone material ages very quickly and it has to be changed every couple years. For this reason, the removable is indicated only when the mouth opening is too limited and when the retention is missing, such as in large defects or in complete ended EDENTULOUS patients. The fabrication steps of the provisional obturator are very close to the definitive obturator steps. So the major difference is the presence of the RPD metal framework in the definitive obturator prosthesis. For this reason, we are going to develop directly the definitive obturator. And it starts with a primary impression. First thing is, of course, to adapt the stock tray for support, either by adding wax or by grinding or modifying the tray. Then block out undercuts, especially of the medial side, with gauze, for example, because you're mostly interested in getting retention from the lateral walls. Inject impression materials in key area with a syringe, and then take an impression of the defect with VPS or alginate, and then a wash impression to record the dental elements. Of course, the side of the defect will influence your primary impression. With tiny defects, viscosity has to be very carefully chosen, as low viscosity goes deeply into the defects and it might stay inside after tray removal. Here's an alginate was used, but with very high viscosity, and anyway the defect was carefully examined after the impression. For this example of a very small palate defect, medium viscosity polyether was chosen for the defect and alginate for the wash impression. A small amount of polyether was put on a gauze used as a tray for the impression. Then the extensions were cut and put back in the defect. Alginate adhesive was put on the gauze, and then a wash impression was performed with alginate, and the two pieces came together. Same here with a bigger defect. Putty VPS was used for recording the defect. Retention were made, and an alginate adhesive was applied on the oral side, and a wash impression was performed with alginate. You can see that the tray was priorly adapted to the defect with wax. Another example here of a rather big medium defect. I made a small tray for the impression of the defect only. I first used putty silicone, and when I was sure I would be able to remove it, I reline it with the interesting borders, at least, with light material. Then, as previously described, I took a global impression. The limitation for this is a bigger difficulty to record the continuity between the defect impression and the dental elements, as you can see here. But this can be useful for patients with limited mouth opening. But if mouth opening is not an issue, another solution is to take a VPS impression of the defect and then to use it again to do wash impression using the same tray for the dental elements. A last interesting technique for huge defects full of undercuts is to make a VPS impression of the interior part of the defect. Make sure you can remove it and put it back in the defect. Then you make an impression of the posterior part of the defect, same process as previously. And then you record the middle of the defect with the previous impressions still in place. And you make a wash impression, and then you can reassemble the puzzle parts to make a cast. Then, once you get your 2D cast, you can fabricate a custom tray. By the way, if you have a RPD framework, you can do an altered cast impression tray, just like any usual removable prosthetics. Anyway, block out the undercuts with wax, except lateral ones, and extend tray 1 centimeter onto the soft palate on the defect side, and full 8 on the lateral side on posterior walls. And you're not very interested in getting the medial extension, as they will be limited with the nasal airflow and by the short lining. The rationale for that design is that the bearing surface of the obturator will be anything that is available for support, such as residual palatal shelf, alveolar ridge contours, the oral side of the soft palate, the tuberosity on the defect side, the skin-lined lateral third of orbital floor, not on this picture, and eventually the skin-lined base of the skull. Furthermore, the obturator will prevent some horizontal extensions for stabilization, retention, and sealing. And these are especially important for retention in EDENTULOUS patients, such as undercuts above the skin graft mucosa junction, nasal side of the soft palate, nasal aperture, and by the way, stabilization can be improved by allowing the obturator to lightweight the prosthesis and by the use of adhesive or implants when movements are still too important. Talking about movements, some other factors may affect the prognosis of the obturator prosthesis, such as dynamic defects, because it's more difficult to obtain a sealing and to get retention. When the residual palatal shelf is parallel to the rotation plane, movements are more important. And neuromuscular control, because it might be difficult for the patient to control the oral functions with obturator, both complete dentures, and the bolus. Anyway, back to the custom tray with the last note. When the access of the lateral wall undercuts is impaired, if, for example, the material keeps being removed during the tray insertion, a hole at the top can allow to manipulate the compound. Then it's the classical border molding of the normal side first, then the anterior 2/3, and then the posterior full height. During this step, it can be interesting to enhance the impression stabilization with an occlusal indexing of the tray, just to make sure it won't move during the next steps. Finally, the wash step can be performed. The wash is performed with polysulfide of light viscosity because you have done a peripheral border molding, and medium viscosity for undercuts only. However, thermoplastic wax or polyethers can be used for dynamic defects, but often it requires to be relined at delivery. Once the impression is done, you will get a huge maxillary cast. Some articulators are suitable without modifications, but sometimes the cast does not fit onto the articulator. So in order to mount them, you may have to create your own articulator for maxillectomies. Fortunately, some literature is available on the internet to modify yours if necessary. Then the wax film is conventional, but it goes into the defect if needed for stabilization. Or the wax rim can be processed when stability and support are deficient, meaning that the definitive obturator is made first and teeth will be added later with resin. Another specificity for limited mouth opening is that the video can be reduced to preserve bolus access and chewing space. The trying is conventional, however, sometimes the lateral incisors can be lifted up of the plane for aesthetics to follow an eventual lip retraction. And you can add a lip plumber for patients with nerve weakness by adding some wax at the corner of the lips. Considering now the RPD framework, the design will often be similar to a clinical class 2 EDENTULOUS. So there will be a high risk of movements such as rotations and translations. These movements will be enhanced by large lever arms. The support will be reduced, especially for residual tapering arch form. And all these risks will be emphasized by the size of the defect. In the end, there is a high risk for abutment teeth overload, especially for teeth adjacent to the defect. The RPD design will respect all the classical rules. But this design will be impacted by the specificities of the defect as listed here, and you can see them on the Foundation for Oral Facial Rehabilitation for more details. Some specificities of the RPD design for abutment teeth adjacent to the defect can be summarized. For example, incisors will receive eye bars, will be splinted with the adjacent for longevity, and will hold positive single rest for directing forces into the tooth axis. Very often, these requirements impose the realization of crowns. In favorable defects, retention and bracing are needed and provided by superposed retainers and lingual plating. Speaking of occlusion, the aim of the defect side is basically to achieve only aesthetic display, lip support, and super eruption prevention. So patients are advised to maxillate on the normal side only, but we know that sometimes they will incise anteriorly, which can lead to some movements. To minimize those, only centric contacts are required on the defect side with no anterior overlap. If the obturator lacks retention, the patient will suffer from hypernasal speech, bolus and fluid leakage, and poor mastication efficiency because the tongue has to maintain the prosthesis. There's, however, a solution for improving these functions, which is placing implants. The preferred locations for implants are the premaxilla and the maxillary tuberosity site. Implants can hold a bar accommodated to the multi-rotation axis, but some other locations are sometimes needed. Immediate implant placement can be thought upon resection, especially for EDENTULOUS patients, patients with localized tumor, and it has to be planned minimum 6 weeks before the radiotherapy treatment. Now let's talk about the obturator of a foreseeable future. As mentioned in the introduction, the development and access to CAD-CAM seem to be leading the evolution of future obturators. We have started using these techniques, but they have not fully replaced the current ones. As a brief reminder, the particularity of the medical CAD-CAM is that we work from the patient digital imaging files, often from DICOM or PLY files. Then we digitally design a personalized object, or we perform a segmentation of this imaging file. The second step is to convert them into a 3D file by creating a digital mesh. And so we need specialized software to produce the 3D files. The last step is the fabrication, and it begins with another software in charge of either digitally slicing the object into layers for additive manufacturing, or to prepare the grinding of a block for milling technologies. So the first step is acquiring patient's geometry. This can be achieved with CT scan, CBCT, or MRI, depending on the structures you're interested in. They only need to be provided by the radiologist as DICOM files, which stands for Digital Imaging and Communication in Medicine. With photogrammetry, you can take photos of the patient with targets and crosses around him that will allow you to perform a 3D reconstruction later. Or with a lab scan, for example, you can digitalize a patient's dental casts. But you can also get these files with an intraoral digital scanner that we'll know. You can also use extraoral scanners that are very interesting for maxillofacial prosthesis, for ear, nose, and orbital reconstruction, because the mechanism is very similar to intraoral scanners. Here's an example of extraoral impression. So you get a cloud of points recorded, a mesh is created, and then the technician can copy-paste the healthy side to the defect side just by playing with the mirror effect. Once you have the patient's imaging files, you need to create the 3D file. So you can use a lot of software to achieve that. You can see here a list on non-exhaustive software that can be used for maxillofacial prosthetics in the publications. Some are free, some require a license, some are easy to use with very limited options, and some are so comprehensive that you need an IT guy to use them. So there is a wide diversity of software for this step. And we'll see some during applications later. And now you have your 3D file. Among numerous other formats, it can be either an Estel file, which is the oldest file format created by with stereolithography by 3D systems. And this format is widely used for computer-aided manufacturing. But it only describes the surface geometry of a three-dimensional object with triangles and without any representation of color, texture, or other common CAD model attributes. The OBJ file was first developed by Wavefront Technologies for its advanced visualizer animation package. It can encode surface geometry of a 3D model and store color and texture information. And now you have polygon file format or Stanford triangle format. It was designed to store two-dimensional data from 3D scanners. And a variety of properties can be stored, including color and transparency, surface normals, texture coordinates, and data confidence values. Then you have your 3D file, and you will meet the next step, which is fabrication machine software. This last software usually comes with the machine you're planning to use. It will be either digitally slicing the object and scaffolds for 3D printing, or place the object into a volume inside a block for milling. So let's see some CAD-CAM applications for obturators. And we'll start with some surgical obturator applications. First, the surgeon can print out the maxillary bone to plan the surgery. This 2D cast can also be used for discussing with a prosthodontist or for educational purposes, either with the patients or with the students. It's very simple to perform if you have access to a 3D printer. With any free software, such as ITK Snap or Osiris, you can do a segmentation of the area of interest on the DICOM files. The software will create a digital 3D model, and you can modify or select anything you need. Then you can print it in resin or in PLA by stereolithography, digital light processing, or fused deposition modeling, which are not very expensive. And we used here a stereolithographic printer, a Form 2 from Formlabs. As you can see, the scaffolds, which were very easily removable. So it's easy to get a model from the DICOM file before the surgery. Many teams are currently trying to prepare surgical obturators before the surgery. So the surgeon digitally draws for the prosthodontic the limits of the future defects. Then the dentist can either print the screw or digitally design the missing piece for the obturator to be ready before the intervention. The limitation here is that the surgeon may not follow the plan during the surgery because sometimes the surgeon has to adapt to some new information. So we actually are working on this concept by printing undersized obturators, which can be relined with a small layer of VPS after the surgery. As you can see, the surgeon performed digitally the surgery. With a Boolean operation, we design an obturator and remove the unnecessary undercuts. We hollow the obturators to be lightweighted, and we print it 10% undersized. The day of the surgery, the obturator is coated with VPS and fitted into the defect. And then it's very easy, later on, to be removed by the dentist. And some teams are already working and publishing about this concept. After the surgery, some other applications can be facilitated by the use of CAD-CAM. In most of these cases, you need the patient to have gone through a post-surgical imaging. An impression after surgery is really uncomfortable for the patient and stressful for the dentist. A way to decrease pressure is to take an optical impression before surgery. Then you can duplicate it and record only the modified parts. Unfortunately, there's a limit with the use of optical impressions because of the difficulty for recording the defect. The tip usually is too thick to get into the defect, and you cannot turn around. But you can merge it with a post-surgical CBCT and get a precise enough cast for fabricating the provisional prosthesis. CAD-CAM can also be used to design a custom tray without primary impression. From the post-surgical surgery imaging, a dental tray with extension can be digitally designed. A lot of dental software, more intuitive than MeshMixer, are offering now this possibility. All you need is a printer and a resin with a good certification, which allows you legally to fit it in the mouth. You can also print the obturator and take it in a wash impression. This is interesting because it eliminates the risk of material going into the cavities and in undercuts during the impressions. You can see on the left picture that a border molding was performed with polyether, probably on the soft palate side. Finally, here's an example where the team asked for an additional localized irradiation. So they were able to perform a precise brachytherapy by printing out the defect. Once printed, they filled it with a denture soft liner resin to obtain an obturator. And then they inserted radioactive seeds where the radiotherapy was needed. And now we'll see some applications for definitive obturators. Of course, as for the rest of prosthodontics, you can use CAD-CAM to make fixed and removable prostheses. CAD-CAM can also be used during surgery for placing dental implants. Implant planning is always very important, but especially for those trying to some unusual approaches, like these implants on the defect side. And finally, CAD-CAM allows to make duplicates that can be used as provisional or definitive obturators. One of the interesting applications is for remaking silicone obturators when they age. Keeping the 3D file allows either to print it in silicone, which is still rare nowadays, or to print a cast that will be poured with silicone. So the current obturator evolution is now driven by the development of materials and technologies. But the field of conventional maxillofacial prosthetics is evolving, benefiting from the rise of converging technologies such as nanotechnologies, biotechnologies, informatics, and cognitivism. For example, augmented reality. Some interesting applications are being developed, especially for communication and education. In this paper, for example, the 3D model of geometrical obturator effect on facial appearance was acquired by superimposing head models with and without obturator prosthesis. Obviously, this could help patients to understand the aesthetic aspect of obturators, as they often suffer from a lack of information. And it can be used for teaching maxillofacial to students, of course. And some biotechnological perspectives are still expected and could be developed for maxillary defects. One can imagine one day an obturator releasing synthetic saliva, for example, or drugs. But beyond the future repaired patients stand the improved patients, the transhuman with additional biotechnological functions, in a perfect symbiosis of surgery and prosthesis, marrying tissues and frameworks, cells and scaffolds. Thank you for your attention. I hope I was not too long, and I'd be happy to answer questions if you have some.